speakers, chairs, and the wonderful audiences of ACNS webinars around the world. Welcome back to another edition of Educational Lectures for You. The speaker for the first session of today is a world-renowned neurosurgeon, Professor Hugues Defoe from France. Professor Defoe is the professor and chairman of Neurosurgery Department at the Montpellier University Medical Center and head of INSERM 1051 team, Plasticity of the Central Nervous System, Human Stem Cells, and Glial Tumors at the Institute of Neuroscience of Montpellier. He is an expert in the awake cognitive neurosurgery of slow-growing brain tumors as low-grade gliomas, a routine which he has developed since 20 years. His fundamental approach is centered on the concepts of brain connectomics and neuroplasticity, breaking with the traditional localizationist view of cerebral processing. For his innovative work in neurosurgery and neurosciences, he was awarded Dr. Honoris Causa several times, and he was the youngest recipient of the prestigious Herbert Oliver Krona Award from the Karolinska Institute in Stockholm. His scientific contributions sum up to 4 textbooks and 285 publications in international journals with over more than 14,000 citations. He is a member of the editorial board and reviewer of several prominent journals, and is also the member of societies like French National Academy of Medicine and Surgery, member of the YNS Award Committee of the WFNS, and the Scientific Committee of the EANS. We are extremely honored to have him today at our webinars, and he'll be talking about a connectome-based approach for the resection of low-grade gliomas and an experience of 1,000 awake craniotomies. The speaker for the second session of today is our honored guest from India, Professor Sushil Patkar. Professor Patkar is a consultant neurosurgeon in the Pune Hospital and Research Center, Pune, India. He is a leading expert in the field of spine surgery and is one of the staunch proponents of the anterior approach CV junction. He is an invited faculty for various workshops and conferences around the world. He is a member of the WFNS Spine Committee and is also a noted author with several publications in various peer-reviewed journals. We are extremely honored to have him today at our webinars, and he will be talking about a simplified approach to CV junction. The chair for the first session of today is our honored guest from Japan, Professor Masazumi Fuji. Professor Fuji is the professor and chairman, Department of Neurosurgery at the Fukushima University Graduate School of Medicine. His research and clinical interests are focused upon brain tumor surgery, skull-based surgery, neural basis of language, and other higher brain functions, and image-guided surgery. He is an integral part of the Japanese Neurosurgical Society and has published several articles in various leading journals. We are extremely honored to have him today to chair the session of Professor Defoe. The chair for the second session of today is our distinguished faculty from India, Professor Atul Goyal. Professor Goyal is a professor and head of Department of Neurosurgery, Lilavati Hospital Research Center, and he also serves as a consultant neurosurgeon at the Bombay Hospital and Research Center and Tata Memorial Hospital. He is also affiliated with the R.N. Cooper Hospital and Medical College as a professor in neurosurgery. Professor Goyal was the past president of Neurological Society of India and is also an honorary member of various international neurosurgical societies. He owns one of the most illustrious careers in neurosurgery, having described many novel approaches in the management of lesions of brain and spine. His philosophy redefined how neurosurgeons around the world manage complex anomalies of CV junction. He is also an avid researcher who has published several landmark manuscripts in neurosurgery. We are extremely thankful to him for accepting our invitation to chair the session of Professor Patkar's lecture. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kata, I would like to sincerely welcome both the speakers, chairs, and all the audiences to this online platform of ACNS webinars. A warm welcome to all our audiences in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel in China. Dr. Liu Boon Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this virtual podium to our first chair, Professor Masazumi Fuji.
Hello, everyone. My name is Masazumi Fuji. I became the professor and chairman, Department of Neurosurgery, Fukushima Medical University in June this year. Nice to meet you again, Dr. Defoe. It is great honor and pleasure to chair this webinar lecture. He is, to me, the best neurosurgeon in the world to treat low-grade gliomas. He is not only a neurosurgeon, but also one of the top neuroscientists exploring the human brain and its function based on his excellent awake craniotomy. Let me talk a little bit about our wonderful encounter. It was 10 years ago for me to meet him for the first time when we invited him to a conference, Japanese Society for Neuro-Oncology, held near Nagoya. Then next year, actually, he kindly accepted my visit to his OR and even outpatient clinic in Montpellier, France. This is when we met for the first time in Nagoya here, and then I visited next year the Professor Defoe's OR in outpatient clinic. It was so wonderful experience to me that my philosophy consideration and attitude toward glioma surgery changed dramatically. Ever since, I have been trying my best to study and explore brain anatomy as well as cognitive and behavioral neuroscience. I'm trying to apply these knowledges to glioma surgery for better quality of life of our patients. Today, we have the giant of this field, and I'm pretty much sure that we will encounter again great excitement. So could you please start your lecture, Professor Dufault?
Thank you so much for your so kind introduction. And we were so young 10 years ago, but I hope that our brain will continue to be plastic now and to create new things, especially to give the opportunity for younger people to reproduce the same results based on this experience now about over 1,000 awake procedures in low-grade glioma. And of course, I will not insist too much now on the fact that localizationism does not exist. I'm sure that many neurosurgeons, but also neurologists and neuroscientists understood that we have to go beyond the classical Broca's and Wernicke's model, and that it's very important, of course, for brain surgeon in general, but especially for glioma surgery, because I'm sure you have seen so many patients in your life with these very big tumors involving the so-called eloquent areas and finally enjoying normal life. So that means that we can play with these mechanisms of neuroplasticity by doing these very extensive resections and by preserving the quality of life, including the cognitive and behavioral aspects we will detail later. And of course, to improve also the understanding of the connectome of the brain. As you said, thank you for that, by trying to be a neuroscientist, first of all, and providing new model of brain processing based on the real truth we can observe not only before and after surgery, but most of all into the operating theater by doing intraoperative mapping. And now with 25 years of follow-up, I'm very happy to say that we were able to improve both the survival now beyond the 17 years in my experience, about 1,000 patients, and to decrease the risk to induce severe permanent deficit in less than 1%, so 99% of reliability when we deal with so-called eloquent areas of the brain. And to achieve this goal, as you know, we decided many years ago to operate earlier by telling that wait-and-see attitude had no reason to continue to be applied in low-grade glioma patients, but also by removing more. And we introduced this concept of supratotal resection exactly when you came 10 years ago. And of course, by preserving the quality of life, thanks to the better understanding of the functional connectome at the individual level. So very quickly, because I'm sure that everyone now agrees with the fact that low-grade glioma is not benign tumor, that the tumor will grow in all cases, that it will become malignant if left untreated, and finally with median survival around 5 years after the first symptoms. What we have to detail is really that if you save time before any treatment, a diagnosis, to do a neuropsychological examination, then you will see that in over 50% of patients, even if they are young, even if they're enjoying an active life, they have already some degrees of cognitive deficits. And this is very important to understand, because the limitation, and I will again and again insist about that, is the connectivity. The limitation of neuroplasticity are the fibers. If you cut them, you will disconnect 2/3 of the hemisphere and the patient will not recover. So that means that even if we left the patient untreated by avoiding surgery, then the migration along the white matter tract will induce some degrees of cognitive deficit. Then we have to be objective before, during, and after surgery by doing a very extensive cognitive assessment. And then the next step is, of course, limitation of neuroplasticity. The brain is doing seizures. And at that time, we met patients and we say that, of course, if the volume is bigger, then the risk of malignant transformation was higher. It has been initially demonstrated by Mitberger in San Francisco, and we confirmed what is just good science. But we introduced the concept of the growth rate, and I will insist again on the fact that before to go to the operating theater, please do a second MRI, calculate objectively the volume, then the kinetics of the tumor. And if a tumor is growing faster, then that means that the prognosis is worse. All patients can understand that. And that this growth rate is not directly correlated to the pattern of the molecular biology. I mean, you can have a tumor growing faster despite the fact that they are oligodendroglioma. And the reverse is that you can have a wild type with a very long survival, which is the case in my experience with more than 80% of patients still alive with 7 to 10 years of follow-up in the subgroup of wild type. Of course, if they had a slow natural history before the treatment. So that means that we have to integrate, of course, molecular biology, but this is not the absolute truth. This is only part of the story. And never my team will take a decision just on basis of the molecular pattern of the tumor. When I started over 20 years ago, median survival in the seminal series in the literature about low-grade glioma was, as you can see, between 6 to 7 years. And for me, it's very important to insist on the fact that we changed radically the natural history of the disease, and we published that median survival was over 15 years, about more than 1,000 cases. So that means that when you cannot remove completely the tumor, please come back, because you will see that we can play with the mechanisms of neuroplasticity over years in patients enjoying normal life. And more you will reoperate, more you will reduce the volume, more you will postpone the risk of malignant transformation, more you will increase the median survival. I mean, it's not imagination. Now we did that. And recently we published with my colleague in Nancy and another paper with more than 16 years of median survival, a prospective collection of data, but the vast majority of cases, as you see, enjoying a perfect normal life over 12 years. So that means that there is no dilemma between the quality of life and the survival. You can increase both. We demonstrated that. So please do it. And how you can do it by dealing with the better understanding of the functional anatomy at the individual level. I will insist on the fact that the brain is different from one patient to another one, but also in the same patient over time, we have to introduce the dynamics of the networks, the meta-networking brain. And of course, this is the reason why it's critical to do functional mapping. The fMRI and DTI are not the absolute truth. The sole possibility is to wake the patient into the operating theater, especially for tumors located within the classical eloquent areas according to the classical localizationism within the Rolandic system, the Broca's area, the SMA, and so on. But fortunately, we have understood that there is a very important dynamics, not only within, but also between networks, evolving over years. And this is the reason why it's possible to reoperate the patient, to remove more tumor, to remove more brain, while preserving the quality of life. So I will insist on the fact that fMRI is not the truth. Why? Because when you have an activation, it's impossible for one-year radiologist or neuroscientist to tell you if this activation is critical or not. And this is what we need. Is it possible for us to remove more brain invaded by the chronic disease? The sensitivity and specificity is very poor. Everyone knows that. We know that resting state is not the solution. Not speaking about a better understanding of the brain. I am PhD in cognitive neuroscience. I love to do resting state before and after surgery. I love to understand better mechanisms of neuroplasticity. I love to use this critical data in order to implement new model of cognition, but outside the operating theater. This is the same thing for DTI. DTI is not the function. Everyone knows that. It's a fact. It's not my imagination. It's based on the movement of water molecules. You know that. This is not the function. If you do not believe me, because you can tell me, today we have advances in tractography. No, please read this last paper published by experts in this field in 2021, demonstrating just for the pyramidal pathway, the variability in the size, shape, densities, connection of white matter tract, if the same data set is investigated by different departments of neuroscience. So everyone knows that this is not the truth. So please, we are neurosurgeons, we are not radiologists. We have to wake the patient into the OR and to do the cortical and subcortical mapping in order to know the truth, speaking about the reorganization of the networks. And it's not an issue, at least for us, because we have a good team. But I say that for 20 years. I'm sure that in many departments in the world, you have good team now with anesthesiologists and neuropsychologists, allowing you to do anatomo-functional correlation into the operating theater. And then it's not so complex, of course, for the patient to collaborate for 1 to 2 hours, especially if the patient had a normal life before surgery, despite, I reinsist, some degrees of cognitive deficits. And then we have to adapt the tasks we will achieve into the operating theater according to the definition of the lifestyle by the patient himself. I mean, of course, they do not want to be hemiplegic aphasic, but I will say again, this is not enough. You are a human being. You need more. You need cognition. You need emotion. You need personality. You need metacognition to anticipate what you would like for the next 10 to 20 years. This is true for our patients, and not just to avoid them to be hemiplegic. So take into consideration the environment. Once again, if you are with an hemianoptia in France, you cannot drive. In North Africa, you can. So the consequence will be totally different according to the culture, the law, the socio-economical parameters. In France, the rehabilitation is reimbursed. This is not the case in US, and so on. But first of all, you have to deal with the connectivity, the limitation of neuroplasticity. If you push too much at the level of the projection fibers, association fibers, you will induce a severe permanent deficit. Even if you're not aware as a neurosurgeon, for instance, modification of the behavior of the patient. This is the reason why younger people should understand definitely that localizationism does not exist, and you can remove Broca's area. You can remove Wernicke's area, but in all cases, you will be finally into the contact in the end, whatever the lobar location of your resection of the connectivity. In this example, the dorsal phonological pathway, the arcuate fasciculus. If you cannot deal with the deep connectivity, you cannot understand the limitation of neuroplasticity. So never you will reproduce these results. Not speaking about extent of resection, speaking about the long-term survival and quality of life of your patient. It's not my imagination. It's not a projection. I have the results. And I achieved that without any technology into my operating theater. If you use DTI, fMRI in your navigation, intraoperative MRI in your operating theater, that means that you do not trust enough in your knowledge of the functional anatomy of the brain while you are a surgeon. And definitely, you will use technology to compensate your lack of knowledge while technology is not able to give you this information. You have seen that in previous slides. So please await the patient, whatever the location of the tumor, because we have a brain, and the brain is, of course, both hemispheres. So we have to take care about the right so-called non-dominant hemisphere in a localizationist view, which does not exist. It's critical to preserve the right hemisphere for spatial cognition, complex movement, semantics, higher cognitive function, personality, emotion, and so on. And of course, it's not enough to say my patient is not hemiplegic, I'm happy. You're happy. The question is, what about your patients and their family? Are they happy? Then you will tell me it's not possible to monitor these kind of functions into the operating theater. And I will answer you, of course it is possible. We did that for many decades. We published so much papers validating these tasks, and especially the administration of multiple tasks simultaneously. The patient should move, should speak, should understand, should self-evaluate himself just in 4 seconds for 1 hour without any rest. And that means that, of course, you have insight into the attentional processing, the working memory processing, the complex movement, the dual task, the semantics, and so on and so on. And suddenly, first of all, you can understand that localization does not exist. I will insist about that because you are under the weight of the history and you continue to believe in the fact that Broca's area is the area of speech. We demonstrated the reverse on the real life. And this year, it has been replicated by colleagues in China, in US, demonstrating that it's true whatever the language, not only in French, but also in America, in English, but also in Chinese, and so on. And even for the first time, neurologists published in Brain this year that Broca's area can be damaged while the patient can recover after stroke. And of course, we send a comment by telling, we know that neurosurgery explained that for many decades since Penfield, and no one would like to accept the truth. Why no one today would like to accept the fact that DTI and fMRI are not the absolute processing of brain. And it's really a pity for patients, because in fact, you can go beyond. You can increase the median survival, not the extensorization, the median survival. You can preserve the quality of life, not just avoiding hemiplegia, but giving the opportunity for the patient to work full time. We have this proof because we adapted the task into the OR, whatever the location, according to the wishes of the patient, including the right non-dominant hemisphere, if you are dancer, to avoid hemi-neglect. But in all cases, to preserve emotion. We are human beings. We need emotion. So it's true for our patients too. I don't know, I don't understand why, but for 1 century, white matter tracts were totally neglected. And today, of course, we will say DTI will restore this lack of knowledge. Not at all. It's just the fact that finally we started to be aware of the fact that we have to preserve the connectivity. And of course, if I explain that we have not to cut, no, we have to preserve the pyramidal pathway, everyone will understand that if you cut the internal capsule, the patient will be hemiplegic. But now I will say it's not enough. If you would like to make sport, to make music, to play a piano, to be a surgeon, to do something complex regarding the bimanual coordination, you have to preserve a network in addition to the pyramidal pathway. And this is true at the level of the cortical areas, but also at the level of the white matter tract. When you stimulate, you can see here, one frontostriatal tract in one hemisphere, you will induce a transitory arrest of movement regarding the bimanual coordination. Of course, you cannot enjoy normal life, despite the fact that you are not hemiplegic. In practice, if you push the resection until the pyramidal pathway, you will induce, of course, a supplementary molar area. And the patient will recover. No, it will not completely recover. It will be totally paralyzed after surgery, and it will be able to walk and to move 10 days later, of course. But it does not mean that it will recover. If you do an extensive neuropsychological examination 3 months later, you will see that it kept some degrees of deficit. So you can also offer the choice to the patient. I will preserve the SMA proper and the frontostriatal tract running to the head of the caudate during the first surgery. Then your brain will have time to reorganize. You will really totally recover. And of course, I will come back by doing a second surgery, because you have seen that you cannot tell me, yes, by leaving more tumor, your patients are living shorter. It's the reverse. Yeah, 17, even difficult for me because I continue to improve each year, 17 years of median survival, because I come back and again and again. And in the meantime, I play with mechanisms of reorganization of the neural networks, and the patients are really enjoying a perfect normal life. The dilemma oncofunctional balance is solved. But we have to apply this concept also to the retrocentral area. If you remove too much the somatosensory pathway, you will induce some degrees of deficit, but also you can induce some modification of bodily awareness and to induce alien hand or fading limb while the patient is not hemiplegic. Once again, if you induce anopia, the patient cannot drive. You will say, my patient is well. No, because he will lose his job because he cannot drive, which is true in 99% cases in France today. You need to drive in order to work. Once again, to avoid hemi-neglect, even in the right non-dominant hemisphere, even posteriorly, you have to weigh the patient to identify the frontoparietal loop, especially the layer 2 of the superior longitudinal fasciculus, and to administrate a line bisection task. And suddenly your patient will be able to dance if he wants following surgery. If it's not critical for him, her, you can push the resection. You have not to decide for him. You have to adapt à la carte. Language, I will not insist on the fact that there is a dorsal phonological pathway, so underpinned by the arcuate fasciculus, which never connected directly the so-called Broca's area with the Wernicke's area, but the pars opercularis to the posterior part of T2 and T3 and not T1. If we do not know the anatomy, we cannot operate the brain. And we don't know the anatomy because it's totally wrong in the classical book of oncology and neurology. Even neurologists, as I told you, published in Brain this year, maybe Broca's area is not the area of speech. Or really, we have to understand that there is a ventral semantic pathway critical to understand. You can speak, but you cannot understand what you say. This is the inferior fronto-occipital fasciculus, the IFOF. You wake the patient, you stimulate, you will induce semantic prophagia. We have to take care about the inferior longitudinal fasciculus. Otherwise, if you cut the posterior part, the patient will have some alexia. If you cut the anterior part, the patient will have some difficulties for lexical access, which nonetheless can be compensated by the IFOF or by the right side, but not completely in some patients. So we have to say, is it possible for you to accept an increase of the reaction time for lexical access? And the patient will tell you yes, no, and you will adapt your surgical act according to his wishes. And if you left a tumor, you will come back in 5 to 10 years. Because in the meantime, mechanisms from neuroplasticity, especially the IFOF compensating the ILF. It depends on each patient, and it depends on this reorganization of years. We are not speaking about glioblastoma. The right non-dominant hemisphere, now if you stimulate the ventral semantic pathway, you will induce non-verbal semantic deficit. And this is absolutely critical if you want to enjoy normal life. Once again, not to be autonomous at home, but to drive, to work, to love. Indeed, we published recently the sole paper in the literature telling we have beautiful results, we are the best, yes, but I have the regret to tell you that my patients are not so well, because in 1/3 of cases, they changed their personality, irritability, disinterest, hypoactivity. You understand that it's absolutely critical to know that before surgery in order to overcome this kind of modification of the behavior, of the mood. Then we introduced a new task many years ago, the read the mind in hours, and by doing, again, stimulation, not only at the cortical level, but the white matter tract, we avoided modification of the behavior. Especially, we understood that the right half was involved in what I like to call mentalizing, namely the possibility to understand the emotion of people in front of you, the empathy. But the right cingulate is very important too if you want to infer the intentions of others. And this is critical for social cognition. Otherwise, you are not hemiplegic, but you cannot deal with others. So very recently, we published papers demonstrating for the first time the real function, not our imagination, not biostatistics like in DTI, but the real truth with different sublayer in the right so-called non-dominant half involved in mentalizing, non-verbal semantic processing, and so on. And this is the reason why we modeled the right hemisphere by telling so many connectivity involved in so many functions. And the neurosurgeon would like to continue to be blind regarding the cognitive and emotional deficit we induce to our patients following surgery, not only 3 months later, but 5 years, 10 years, 15 years, 20 years. I can tell you it because I have this follow-up. I continue to meet the patients. And the question was, in the meantime, did they enjoy a real normal life? I mean, by doing what they would like to achieve in their life, even if they had no brain tumors. And this is the reason why we incorporated the self-evaluation task into the OR. We published that this year in order to preserve the metacognition, knowing of knowing. So critical to elaborate your strategy as a human being to develop what you would like to do for the next 10 to 20 years, even without brain tumors. Fortunately, we can play with these mechanisms of dynamics in the brain. And the vast majority of neurosurgeons, I know, did not understand, that when they do a surgery, even under general anesthesia, it's because the brain reorganized before. And we demonstrated, for instance, that when you have an insular tumor, which is very frequently low-grade glioma, in the contralateral hemisphere, you had already an increase of the volume of the other homologous area. Then an increase of the functional connectivity based on this increase of volume. Then you can play with these dynamics occurring before your surgery, before the diagnosis, by being aware about that or not. And of course, I prefer to be aware about that because I will try to direct this mechanism from neuroplasticity following surgery. And then longitudinal fMRI will be absolutely critical in order to explain to us how a patient can recover after a SMS syndrome, even if, once again, it will not totally recover, thanks to the balance between both hemispheres. So what means non-dominant hemisphere? And then by pushing this plasticity, especially thanks to postoperative cognitive rehabilitation, and by preserving the connectivity, you will come back. And in the vast majority of cases, the surgeon did the resection and refer the patient to an oncologist in order for them to do radiotherapy. No, do not apply this concept. Continue to follow patient by yourself. Induce plasticity, especially for him by doing a normal life, by enjoying normal life. And then you will come back before radiotherapy. And then you will remove more. And then you will preserve again the quality of life of patients. For instance, by removing the second time vernicose area, which was critical during the first surgery, removing the so-called Broca's area, in this case, critical for semantic processing. I hate to lose, I came back 10 years later, I remove more, the patient is still alive, enjoying normal life without chemoradiotherapy. And sometimes you can even do a very extensive lobectomy in both hemispheres because mechanisms of neuroplasticity occurring in the meantime with 5 hours of cognitive examination, 3 months following the second surgery, demonstrating that plasticity mechanisms are beyond our imagination if you continue to believe on classical localizationism. So the most important for me, the results. In so many now meetings, colleagues are showing beautiful image in DTI, fMRI technology, but never we know how their patients are. I mean, 5, 10, 15, 20 years later. Remember, the goal as medical doctor, and especially brain tumor surgeon, was for our patient to live longer and better. I achieved this goal. Indeed, only 0.5% of my patients had severe permanent deficit with no mortality, but also with 86% of cognitive preservation. This is the first time it's published in the literature. We published it in Oncology just 1 week ago, with 10% of improvement of cognition, 94% of return to work with an impact, of course, on epilepsy. This is the real truth, and not just I resected the tumor according to the postoperative MRI. We do not care. What we want is, first of all, for the patient to return to a perfect normal life. And then you will see that nonetheless, you will increase the median survival. Of course, we can increase also the control on epilepsy if you increase the resection beyond what we can see on the MRI, because as you know, the epilepsy is not related to the cortex at the level of the core of the tumor, but the periphery. And for the first time, again, we published recently this paper in Journal of Neurosurgery with demonstration of mechanisms of neuroplasticity during the first and second surgery, but also during the second and the third surgery. And I started between the third and second surgery with median survival of almost 18 years, never reported in the literature, in patients enjoying perfect normal life. In my whole series with 1,000 cases, almost low-grade glioma, because it's changing according to the new classification. Suddenly you don't know if a wild type is still a low-grade glioma, because it seems that it's a glioblastoma. But if the patient is still alive 20 years later, maybe molecular biologists have also to take into consideration the real truth and not to impose their view based on just samples into the lab. I speak about human beings. They are living more than 17 years because I did more and more extensive resection, because mechanisms of neuroplasticity. And this is the concept of supratotal resection, to do a lobectomy when you can, and not just to believe that the flare is the tumor. And suddenly, no death with more than 15 years of follow-up. And it has been replicated by other departments, like in Milano, for instance, thanks to Lorenzo Bello. So of course, the goal is to arrive earlier and earlier and not to wait. So incidental low-grade glioma, please do extensive cognitive assessment without any a priori. You will see that more than 50% patients with incidental discovery of low-grade glioma have already some degrees of cognitive deficit. Of course, there is a brain tumor, but you will remove more because the tumor is smaller. So you will increase the rate of supratotal resection by arriving earlier. But you will not induce any severe permanent deficit because mechanisms of neuroplasticity are more efficient, rather than to wait that the patient has 10 seizures per week, for instance. And once again, we replicated exactly the same results. We published recently in Oncology, not only in Montpellier, but also with UCSF, with Udine and Calgary, with this series with 267 incidental low-grade glioma in 4 departments. And you can see the 10-year overall survival over 93%. And of course, they enjoy a normal life because no seizures, and because we published, again, for the first time, the neuropsychological assessment, not only before, but also after surgery. I believe on truth. So not just, I am surgeon, I know that my patients are well. I want to see the median survival, I want to see the cognitive scores, and I want to see the return to work rate, 97% in our patients with incidental resection, and incidental low-grade glioma resection. This is the reason why we proposed a screening policy between 20 to 40 in the general population in France. And of course, to achieve this kind of results, once again, we have to see the brain into idiopathic field, and especially the limitation of neuroplasticity to help younger people. We published many atlases of the critical networks, the limitation of neuroplastic potential, which is much more limited by the white matter tract. And you can use this atlas in order to build your mental imagery more quickly. And then you will apply this concept not only for glioma surgery, but also for metastasis resection, for cavernoma resection, for epilepsy surgery, and so on. But speaking about chemotherapy, of course, we will use it before radiotherapy each time there is an invasion of this white matter tract connectivity, and when this is the limitation of my resection. This is what we call the minimal common brain. If you cut them, you will induce severe permanent deficit. But this is true also for radiotherapists. And they do not want to admit that because they are not following their patients for 5, 10, 15, 20 years. If they did that, they would see that they have a decline of cognitive functions, even with the new technology. And on the other hand, it has been demonstrated that early radiotherapy does not change the median survival in comparison with late radiotherapy. So why not to postpone? I don't know. In my series, it's exactly what we did. And as you have seen, my patients are living longer and better because we know the limitation of neuroplasticity. So we will operate to induce mechanisms of reorganization by doing a second surgery 5 years later, or 4 or 6, and by coming back a third time, and if it's not possible, by giving chemotherapy regardless the molecular pattern. How do you want for a biologist to explain to you how the brain is processing? We have to integrate the clinical, neuropsychological, radiological, dynamics, and finally neuropathological parameter at the individual level. And suddenly you increase the median survival and the quality of life, even in patients with foci of malignant transformation. For a long time, I said in Montpellier, there is no low-grade glioma anymore because by doing lobectomy, we identified foci of malignant transformation in more than 90% of low-grade glioma. And no one would like to admit it because at that time they did just a biopsy. And suddenly they did a lobectomy and they said, there are foci of malignant transformation. Really? You think that it's not a continuum? And suddenly they said, if there is a focus of glioblastoma in the middle, we have to consider this is a glioblastoma. No. If the tumor is growing slowly, if you did a supratotal resection, please do not perform systematically adjuvant treatment. We are crazy, 5 years survival rate over 95%. Focus of malignant transformation, complete resection of the flare, no chemo, no radiotherapy. I reoperated on the patient. 15 years later, still alive with 20 years of follow-up, no chemo, no radiotherapy. You can change radically natural history of the disease if you push the resection according to the dynamics of the networks. So please be a scientist, understand better, please participate in the investigation of mechanisms of neuroplasticity, especially by understanding the balance between hemispheres. There is no dominant versus non-dominant. This is just the imagination of neurosurgeon. Please apply this concept to movement, language, but also higher executive functions, attentional processing, or even metacognition, knowing of knowing. You will tell me it's just research. No, you need to anticipate what you would like to do for the next 2 decades. Otherwise, you are not a human being. It's true for you. So it's true for my patients. And once again, to help younger people, we published another atlas past year in the MRI template with the critical networks. fMRI is not able to tell you this is critical or not. It's intrinsically related to the methodology. Everyone knows that. They will not acknowledge that. But we know, we have demonstrated where are really the critical cortical and subcortical white matter networks involved in 16 functional domains: language, phonology, semantics, and nonverbal, mentalizing, metacognition. Okay, you have understood. If you know this atlas, you can navigate in the brain. And to help younger people, we develop a software allowing to match the MRI of your patient to this atlas, which is just a probabilistic atlas. So never use this atlas into the operating theater. If one guy is telling you, please use my atlas into the OR, he will lie. It's not possible. We are unique. Each brain is different. Each brain is different in the same patient over years. So now the last point before to conclude is to better understand these interactions between networks in order to create what we are, human beings, namely adapted behavior. So first of all, once again, we have to understand the connectivity within both hemispheres and then between hemispheres. And now we have to put everything all together to understand that the brain is unstable. That means that you have a perpetual succession of new equilibrium states according to what happened in our life, not in 1 year, but just in a few seconds, if there is an alarm, for instance. And it's exactly what happened into the operating theater. When you stimulate, if you do not ask a patient to do at least 2 tasks simultaneously, like moving and speaking, you will never understand that patient was still able to move, to speak, but not to do both simultaneously anymore when you stimulate. And then you will say after surgery, my patient can speak, can move, yes. But do you think that he will be able to return to normal life, including to work full time? And say, no, but because chemotherapy, radiotherapy, first of all, do not irradiate the patient. Second, do post-operative cognitive rehabilitation. Third, push him, her to return to normal life. And you will see that suddenly it's possible. If you did the rehabilitation by understanding that you will reinforce the link between networks, for instance, to compensate the resection of the so-called Broca's area, you need not only the network of language with the dorsal pathway, with the ventral semantic pathway, as we have seen, blah, blah, but also the interactions between the so-called language pathway and the executive function, working memory, mental flexibility, attentional processing, and so on. It's exactly what we can model thanks to resting state fMRI. Of course, I love fMRI to explain to me how the brain is processing, and especially longitudinally. But at the individual level, at that time, this is not the truth. And finally, the last publication I made this year regarding the concept, the new concept of metaplasticity, means that, of course, the brain is reorganizing, because when we do the first surgery in low-grade glioma, the brain reorganized for many years, but it followed its own pattern. And my goal would be now, not only me, of course, but to change the pattern of reorganization, for instance, by recruiting more the contralateral hemisphere rather than the perilegional area. Of course, when I will come back a second or a third time, then according to this principle, I will remove more. Then I can tend toward the supratatorialization, while if the brain compensated around the tumor, of course, you will do only an incomplete resection during the second surgery. So this is the reason why I proposed to take into account in the long-term management of patients with low-grade glioma about the glioma instability, the brain instability, the metaplasticity, and so on, I will not insist. And you know what? None of these parameters are actually taken into account in the classical guidelines about low-grade glioma published in Lancet. That's crazy. We do not take into account of the brain itself. How do you want to take care of your patients? We cannot accept that. So I do not accept. And I will continue to make them happy for a longer time by taking into account their wishes, by dealing not only with the tumor per se, but with the brain of each patient evolving over time. This is the reason why technology into the OR for younger neurosurgeons cannot help you. It will be a limitation of your own learning. You will become addicted you will not be able to operate the brain without your navigation. And finally, you will understand nothing about meta-networking brain. That means that you will not become a neuroscientist, while your generation should be the perfect reunification between neurosurgery and neuroscience. So now you have the choice to become first a neuroscientist and to better understand these mechanisms, and by going beyond my own knowledge regarding the understanding of neuroplasticity, meta-network, and even metaplasticity, and to apply it to low-grade glioma surgery, but also high-grade epilepsy, as I said, but also DBS, functional neurosurgery, BCI, or just to continue to remove a tumor mass according to the neuronavigator into the OR, and finally to change nothing about the natural history of the disease. You have the choice to make, and this is the principle of metacognition for you. So good luck. Thank you so much for your attention.
Thank you very much, Professor Fujii.
Thank you very much, Professor Dufault, again. Every time I listen to your talk, it causes my excitement in my heart and brain. Thank you very much. And probably the key, I think it's brain has a big plasticity, if the surgeon knows the brain very well. And I'd like to ask you about surgery. Maybe, do you think that the surgery may facilitate these kind of plasticity? So compared to the, if you do not do the surgery, the plasticities, extent of plasticity is not so high, but maybe, I don't know, but if you do surgery, the resect part of the tumor, or maybe most part of the tumor, it may enhances, maybe promote plasticity. Do you think so? Or it's not related to the surgery?
No, I do not think about that or believe about that. We demonstrated that. I mean, in essence, in 90% of patients with low-grade glioma in front of you, you did the diagnosis because of seizures. And it was too short to detail everything, but I have shown a slide. We modeled the fact that seizures means that the brain plastic mechanisms reach a first level of limitation. So that means that even if the patient was able to compensate for many years by increasing the volume of the contralateral side, the connectivity, and so on, so with no symptoms, finally one day the brain said, stop. So if you arrive at this time, of course, if you control seizures, if you remove the vast majority of the tumor, that means that you have at least a chance to give again the possibility for the patient to have more plastic potential while he reached the limitation. So in all cases, if you do nothing, the patient will have a decline of the cognitive function. With a surgery, you will induce it. Now the question will be how much you can remove, because if you left too much invasion of the white matter tract in a very diffuse glioma like a gliomatosis like, then this is the reason why we have to give chemotherapy very quickly in order to avoid the dissemination in this minimal common brain. Otherwise, in all cases, the plastic potential will remain limited. But if you remove the vast majority of the tumor since the first surgery, or a fortiori if you achieved a supratotalization, then you will see that the patient will improve his cognition 3 months, 1 year, 5 years after surgery. And again, it will have a decline of cognitive function while the tumor will start to migrate too much. And again, it will be the good timing to deliver adjuvant treatment or to reoperate or to give chemotherapy. And it's exactly the game, if I can say, we continue to apply with 20 years in follow-up in patients who had 4 surgeries. And the problem is that we really arrived at the level of the minimal common brain. So I cannot re-operate the patient. And we used, in the vast majority of cases, at least 1 to 2 cycles of chemotherapy. So now this is the good timing to irradiate.
I see. Thank you very much.
Thank you very much. We can take comments from Professor Suresh Nair and Professor Atul Goyal, sir, also.
Yeah, what a great lecture, Professor Dufo. Every time I listen to you, I learn a lot. And you are, in a nutshell, you told that functional MRI and DTA, they are just what we all follow, but you have stressed the importance of cortical, subcortical, and cognitive mapping. Just a couple of questions. One question I am, this you told about incidental gliomas. What is your policy in picking up incidental gliomas in France? In India and all, only when they get MRI done for some other reason, like after a head injury or something like that, only we pick up this incident glioma. And you told how important it is to pick up asymptomatic. You told 50% of them still will have cognitive affection if you really examine them. And what is the policy in France for picking up incidental gliomas? Like in Japan, they pick up unruptured aneurysm. And then second question is, you told there is no difference for you between right and left brain. For you, brain is same, whether left or right. You told about 16 white matter tracks which you try to map during surgery. I just want to ask one question which I have studied, and I teach people that right hemisphere is for prosody of speech. And if so, if you believe in that, how do you assess prosody of speech while doing surgery, awake surgery?
First of all, regarding the first question, incidental diffuse low-grade glioma, of course, we will prone to arrive earlier, but by demonstrating, first of all, that there was an increase of the volume. I mean, never I rejected, for instance, multiple sclerosis because I have seen incidentally flare hyper signal. First of all, I will do a second MRI 3 months later. And if there is an increase of the volume, that means that this is a low-grade glioma. And that means that we have to remove it, otherwise we know what will happen. On the other hand, I have many patients with a perfect stabilization of image, I don't know what it is, incidentally discovered, and I will be the first to say, do nothing, you have a normal life. I will just do a non-invasive repeated MRI without doing a biopsy, of course. So just common sense. And by explaining that to patients coming from France or even elsewhere, sometimes I operated on patients coming from India with just a regular follow-up. And I said, no, now we have to prove that it's growing, it's a tumor, even if you have one. So please accept surgery, because we know that you increase the chance to remove more and then to avoid malignant transformation with over 15 years of follow-up. It's demonstrated. Now, regarding the right non-dominant hemisphere, what means is not I believe or not. I mean, please, if you agree, ask to your patient, you operated on in the right so-called non-dominant hemisphere without glioblastoma or radiotherapy. Do an extensive cognitive assessment while you have the feeling that they are well, and you will see the vast proportion rate of cognitive emotional deficits they have. And then the question will be, is it possible to avoid them? Yes, by doing so, mentalizing task, multitasking, and so on into the operating theater, I will not redetail. Now the question will be, is it absolutely critical for this patient? I will not impose, of course, to the patient to be awake with so many tasks, but I will propose, what do you want? Which is more or less never done by 99% of neurosurgeons, just applying their protocol according to the fact that they believe or not. I do not believe, I believe on results. And then in fine, they will tell me, please remove more tumor to have some modification of the behavior. I do not mind, because what I want is to live longer. And okay, I will remove more by cutting eventually the IFOF. it will be the absolute proof for me that this is critical for the mentalizing, because sometimes I did that. And of course, we did an extensive cognitive assessment 3 months later, and the patient did not recover. Or they will tell me I am in Montpellier in order to preserve a perfect quality of life, because the most important for me is to continue to enjoy familial, social, professional life. And then I will, of course, tell them I need your motivation. And this is the trick also, because of course, if they agree to help you during surgery, if they agree to do a post-operative cognitive rehabilitation, even if they have the feeling that they are well, I can tell you that after that, they will not be depressed. And this is the point. The vast majority of my patients can continue to enjoy a normal life, even if they can be irritable, which is a little bit different. But since the slide we have seen, thanks to our colleague, when he came to Montpellier 10 years ago, I have the feeling that I am a little bit more irritable 10 years later. So I don't know if it's pathologic or just ontogeny.
Professor Dufau.
Yeah.
I want to ask you one question.
Please.
See, there is no question about, the importance of the brain and all those things. You were talking about tumors in the supplementary motor area. Mm-hmm. And as we know that tumors, low-grade gliomas in the supplementary motor area are quite common. Maybe you mentioned about 20% or 25% of low-grade gliomas are in supplementary motor area. Now, I want to know, you see, the general feeling is that you remove the tumor in the supplementary motor area, you may have some deficit of speech and of limb weakness, and that recovers over the period of 2 weeks, 3 weeks, 2 months, 3 months, it recovers. Now, I want to know, and you were mentioning about your strategy of staging of operation and neuroplasticity and all. Can you just summarize, if there is a supplementary motor area tumor, how you do? Just summarize for me, because I want to know exactly how you do and what are your results. Do your patients develop postoperative weakness and speech problem, and do they recover or do they do not develop, and what is your experience, Dufau?
First of all, what means SMA? I mean, as you know, we have at least 2 parts. The first with the pre-SMA, which is almost in all cases invaded. You can remove it, the patient will totally recover, I totally agree. And the SMA proper itself, approximately the last 7 millimeters just in front of the paracentral lobule with the frontostriatal tract. I'm speaking about that. If you remove it, you will induce the complete SMA syndrome with a total akinesia and in the so-called dominant hemisphere, total mutism. And then I agree, you will see a recovering of the mutism and akinesia 10 to 20 days later. But if you do an extensive cognitive assessment, then you will see 3 months later that the patient did not completely recover. For instance, if the patient is a pianist, he will not be able to play like before surgery. You will tell me, we do not care. No, it depends. If the pianist told me before surgery, I want to continue to play piano with a high level because this is my life. So according to it, I can tell you that your patients are not perfect. I know it because I thought when I was younger, when I have seen clinically this recovery, that my patients were well. And finally, one day we had a PhD in cognitive neuroscience who examined my patients a posteriori. I thought they were perfect. And finally, we have found so many deficits regarding more accurate, of course, cognitive issues. So now, if the patient, according to this definition of the SMA and what means recovery, I explain everything to a patient with this kind of tumors by telling, can you accept this slight but objective deficit, not just immediately after surgery, but for the long-term life? If they are telling me, I do not care, remove as much as we can. Of course, I will push until the pyramidal pathway. I will induce a complete deficit. The patient will recover, but he will never play golf anymore, for instance. Versus the patient is telling me, I am a sportman and I need absolutely to swim, to win, and so on, to preserve this coordination, then, or the reaction time. Also, otherwise, you have a risk to see an increase of the reaction time just to find words or to have the good strategy regarding the sequence of action, the conation. Then I will stop until the frontostriatal tract. So that means that finally I will remove all the tumor except more or less the 5 posterior millimeters. So you will see a rim of flare hypersignal, which was expected, but the patient will have just a very transitory deficit and will totally recover. It will tell you, thanks, I have a normal life. And you know that, of course, there is a residue. The residue will continue to grow. But in the meantime, because you will push plasticity, thanks to the fact the patient will recover and return to a normal life with this higher level, is a golfer, a pianist, what you want in this example, then you will come back a few months to years later, you will remove the so-called SMA proper and the frontostriatal tract, which in the meantime compensated thanks to the contralateral side, and you can demonstrate it thanks to longitudinal fMRI. And during the second surgery, you will remove what it would have been possible to remove during the first surgery, but without any permanent deficit. And finally, 10 years later, the patient had exactly the same oncological prognosis, but had a perfect normal life in the meantime, according, once again, to his wishes, because if he told me before surgery, please remove everything, I will do it. So it's really a strategy à la carte.
Thank you very much, Professor Goel and Professor Defoe. Any further comments, Professor Goel?
No, that is fantastic. There is no question about the contribution of Professor Dufault in promoting and developing low-grade glioma surgery throughout the world. His concepts and his vision, we all know now through his various lectures. And I will just let the audience know that recently there was a very big survey by Stanford University, and they assessed the neuroscientists of the whole world, not just neurosurgeons, but chemists and physicists and all those things. And that database was used to evaluate the neurosurgeons of the world. And Professor Dufault was #1 on that list by virtue of his papers, by virtue of the impact of his papers, and by virtue of his following. So I congratulate Professor Dufault for getting this unique honor in the world of science. Professor Dufault.
Thank you so much. And thank you also for these invitations and discussions, because it will continue to push my own plasticity, because I would like to continue to give you new insights in the next future.
Thank you very much. That leaves without doubt who our honored guest is. Thank you very much, Professor Defoe. We learned a lot from today, and remembering one of the great surgeons who said that the lesser I know, I am a better surgeon. So there is a lot to learn from you. Thank you very much. We can hear the concluding remarks from Professor Masazumi Fujii.
Thank you very much. We got a very big inspiration from Professor Defoe, and I think this webinar, contributes to all our, guests in this webinar. So thank you very much again, Professor Defoe.
Thank you very much. I would like to inform our viewers that this webinar has been broadcasted on WeChat, Zoom, and YouTube, and as of now, we have more than 1,300 people who are watching live across the world.
Once again, it was a great pleasure and honor for me, but I will leave you now.
Thank you very much, Professor Defoe. Thank you. So now we'll move on to the second session, and I would like to invite Professor Atul Goel to say the introduction part and invite Professor Patkar in turn.
So it is my great pleasure and a big honor to invite my dear friend, Dr. Sushil Patkar, to give his thoughts about craniovertebral junction. Dr. Sushil Patkar is from Western India, and I have seen him as a small little boy, then seen him grow as a man, and now seen him as a very popular speaker and orator on this subject. Dr. Sushil Patkar has worked quite heavily and quite dedicatedly and in a focused manner on the subject of craniovertebral junction. And there is, it will not be wrong to say that his motivation, his belief in his own self, he does what he believes and he says what he believes, and he's completely firm on what he believes. So with that kind of notion, he has achieved what he has achieved, and that we will all now see. But it is my great pleasure to have him on board, Dr. Sushil Patkar.
Thank you, my dear friend, Professor Goel. I don't know if many of you know that I began in neurosurgery because I was almost dragged into neurosurgery by Professor Goel. I owe my entry into neurosurgery to Professor Goel. And I'm so lucky today to see that none other than him is the chairperson for my session. There could not be a bigger happiness for me that I am going to sit and present my work when he is there as the chairperson. I thank my friends. What has happened? There's something wrong with the screen? Yeah. I thank Professor Raja and the ACNS for this opportunity. And I will be speaking on simplifying craniovertebral fixation. This has been a kind of, the most difficult part of neurosurgery is fixing the skull and fixing the first two vertebrae. You all know that it's between the deep sea and fire on one side, the vertebral arteries, the spinal cord, and many people get deterred by this surgery. We all have seen the contribution of Professor Goel for craniovertebral fixation, and he has been a source of inspiration for me. And that is what kind of programmed me to work and try to make it simpler, because everybody cannot become Dr. Goel, So I have no disclosures except the people who taught me neurosurgery. Professor P.S. Ramani was the past president of the WFNS Spine, and Dr. Vengsarkar. And of course, my philosophers, Osho. I don't know how many of you know him. He's a great philosopher from India and who looks almost like Professor Goel. Just see the similarity. Anyway, so I'm going to simplify. Simplify means finding a smaller, straighter, safer path. So we all know that C1, C2 fixation, rotation is the predominant movement, and any operation that stops rotation will fix the atlantoaxial joint and treat the instability. Megal, 1986, described this operation, and it was a good operation, except that in 30% of the time, because of the vertebral artery, you could not do it. And then it remained for my dear friend Atul Goel way back in 1994 to describe his technique of plate screw fixation. But somehow the world neglected it and started, projecting it as Dr. Harm's technique in 2001. But, he had preceded him by more than 7 years. So I will draw your attention to read this paper, my dear friends, in which you will find how it took such a lot of, hard work for people like me to, see that people understand that it is not Harm's Goel technique, but it is Goel Harm's technique. Anyway. In spite of all that, if you study the vertebral artery has a varied course in the subfacet of the C2. And in spite of all the precautions, there is always a small but definite chance of injuring the vertebral artery. Necessity is the mother of invention. Research is search again. There is a flaw in the CT scanning of the spine because the CT scan, they don't tilt the grand tree properly. You will always find that there is dense bone under the facet. Whatever happens, the vertebral artery never comes into the facet, and you will always have dense bone in the facet. And if you focus properly, and if you pass a screw just below the facet, downwards and medial into the vertebral body, there is no discussion about vertebral artery. See, most of the surgery of C1, C2 fixation has revolved around the vertebral artery, how to protect the vertebral artery, what to do when there is bleeding, how to prepare the joint, and how to avoid injury to the spinal cord. If you take this trajectory just under the facet joint into the vertebral body, this discussion comes to an end. So now I'll show you some examples. So you see this is atlantoaxial dislocation, and you see this is fixed. You can see that the screw is passed just under the facet, and these screws are divergent screws, mind you. See this, pay attention to this. This is another example. You, in a polyaxial screw system, you need not bother to have the screw heads one above the other. They can be below, and anyway, as long as you tighten the rod, it is going to get fixed. Now, this is the case of high riding vertebral artery, and you can see how the screw is passed under the facet. And you have to remember the divergent screws are always superior to parallel or convergent screws. Whenever you pass screws anywhere, whether it is lumbar spine, dorsal spine, C1, C2, the screw construct has to be divergent screws if you want a more rigid fixation. So when this technique described by me is the screw is biomechanically in a superior position, it got published way back in 2016 as a new entry point for C2 screw fixation, significantly reducing the possibility. Now, this significantly word was because the editor was not ready to accept 0% injury to the vertebral artery. So they were a little worried, and they made me modify the title, but actually there is 0% injury if you pass the screw under the facet. Of course, it got published at other places. But then again, I found that this basically a polyaxial screw rod system came into existence in the lumbar spine because you could not bend the plate sideways. For a single level fixation, the plate screw fixation is always more rigid and more solid as compared to polyaxial screw. If you want to manipulate the C1, C2 joint, you need a plate screw construct and not a polyaxial screw rod construct. So you see this is the technique where you can modify and make use of a plate like a pedicle screw, and this can be used to manipulate the C1, C2 joint, which you cannot with in the polyaxial screw construct. You have to rely on head positioning. So this was subsequently published and presented at many places. The advantage of a plate screw construct is that you can compress the joint and you can get earlier fusion as compared to polyaxial screw rod construct. Then there were modifications in the plate, and the concept was very simple, that you pass like a pedicle screw, you pass the screw inside. There was, you can put a bone graft or a cage, whatever you want, and you can see this VSP plate where there are multiple holes to readjust where you want to position the screws. And once you get that particular position, you tighten the construct. Yes, it is easier to, this video was, later on published where you can see how this plate screw construct was done. And during surgery, you have to notice that when you pass and make the holes very close to the facet and pass the screw downwards into the C2 body, you are not going to have the problem, and you can reduce it on table. For example, you see these are the polyaxial screws which have been passed, one under the facet of C2, and then this is special plates devised for me by Geon company, and then you position these plates, and you can manipulate the screw rod wherever you want with customized instruments, and you can get the reduction of the joint. Of course, you should have opened the joint very well before doing that, and you can see this. This is how you can manipulate the C1, C2 vertebrae into the position that you want on the under the C arm before you tighten the top knot. Anyway, this has got published in JNS, and those who are interested, they can review this in JNS Neurosurgical Focus video. Then, of course, still in spite of that, there was always a problem of the posterior surgery, which I did not find appealing, was the venous bleeding. And it was a cantilever construct. That means you are trying to manipulate the vertebra from behind. Of course, the anterior surgery was more direct. Trying to control vertebra from behind is like sitting like this. If you see the literature in lumbar spine, the entire literature is now shifting towards ALIF and anterior surgery. And most people are finding the results are, if not better, almost the same with lesser complications. Why is it better? Because the weight transmission is along the spine. Whenever you're trying to talk about fixation, you have to see where is the weight transmission. The weight transmission in the cervical spine, upper cervical, from the condyles to the lateral mass to the facet, and very little weight is transmitted behind. Therefore, you can find sometimes the vertebral artery is very high riding, but that does not mean that the patients get any kind of instability or fractures, because the weight gets transmitted like this. And therefore, you must, whenever you are contemplating fixation, you must contemplate fixation over here. As long as the mandible goes above the C2-3 disc, which happens in 95% of the time, it is very easy to access the C1, C2 joints, just like an anterior cervical fusion, just like an anterior cervical fusion. If you will see cervical spinal surgery, it was all from behind till Smith, Robinson, and Cloward started doing it from the front, because the people soon realized that biomechanically, it is much simpler. You're just going through muscle planes, detaching only the longest scoli muscles, and then removing the disc and getting the best fusion rate and success rate is when you operate from behind. As compared to behind, when you're going to operate, you're going to detach all these muscles. You're going to detach the posterior tension band. What is causing the flexion, what is causing the deformity is the longest scoli muscle and the longest capitis muscle. We have to remember that bones are formed after the muscles. If a person is having a congenital craniovertebral anomaly, that is because of the abnormal muscles. If you will focus and review the scans of patients with congenital craniovertebral anomalies, you will always find that the C2 spinous process is big. Why is it big? It is because the muscles are trying to protect and keep the skull and preventing it from dislocating anteriorly. Now, if you want to go there and disrupt all that muscle attachment, you are just adding insult to injury. You can reach this area very safely, very easily from the front. It is traditionally we were programmed to go and from behind, because in those days microscope was not available, and therefore the posterior surgery became very popular, but it is time to rethink. So now you see the difference when you're going, you want to manipulate the C1, C2 joints, which are actually in abnormal position because of the overacting muscles. We were born in a flexion position, the muscles formed earlier, the bones formed and got ossified afterwards, and now you want to go and disrupt these muscles which are trying to hold the head in extension is bad physiology. From the front, there is nothing. The bone is staring at you. You just have to go across the bone, prepare the joint. In any spine surgery, the most important part I feel is the fusion, that is preparing the joint, debriding the joint, and passing the screw across the joint. Like this, the direction is safe. There is no discussion about the vertebral artery or the venous plexus bleeding, which is the most deterring fact for young surgeons. And the trajectory is upwards and outwards. You can use plates. There are these, it do not require a lot of instrument, just a micro drill and maybe just a C-arm, and maybe long right angle retractors to look into depth. I hate self-retaining retractors because they are not under your control. In India, there is no problem in having assistants, So you have right angle retractor, you know just exactly how much pressure to apply. Plus, they can be changed in direction as you move from one side to the other joint. Not too many instruments and very simple implants. Now, these are some examples. You can see this. You can see there's a fantastic opportunity to graft the joints, and you can expose the joints, put your drill inside the joint, prepare and the secret is to get bleeding from the end plates. If you get bleeding from the end plates, then you're going to get a fusion. All these implants, screws or posterior screws or polyaxial screw rods, etc., they have a role only till there is bony fusion. If there is no bony fusion, then the implant is useless. You're going to get happy just with the immediate post-op X-ray, only for it to fail down the line. So focus on preparation of the joint, focus on getting the bone grafts in the joint, focus on bleeding from the end points. Don't get mesmerized by screws. So these are some examples you can see, and other examples, and an example. And you can see sometimes I use bone grafts, and you can see long term, you can see it getting fused. Is the tricorticate bone graft, and then plates and screws, various examples. So then this is fracture. You can see this chronic fracture, which is treated by bilateral anterior transarticular screws. And the essence is to get fusion of the joints. Now you can see this. When you do anterior surgery, the surgery is through muscle planes. The movement of the neck remains unrestricted, except for little restriction or rotation. Flexion, extension remains unrestricted because the posterior tension band is intact. You are going from here between the muscle plane, just detaching some longer scoli and nothing more than that. There's no hypoglossal injury. And these are the implants. And the end point over a period of time should be this. If you are going to see this at the end of 6 months to 1 year, then you have done a good operation. Anything short of this is not a good operation. Anything short of this is just being happy with the implant. And of course, you can have complications like this where you become a little overconfident and don't check properly and the screw went inside. Of course, now with neuronavigation, it is very unlikely that such situations will happen. And this is another example in case of implant failure when I was not using locking plates. And then sometimes you have to remember the lateral mass. You must study the lateral mass very properly on the preoperative CT scan. Sometimes the lateral mass is a very, very dense bone. It hardly has any cancellous bone. So you must use a proper drill and proper tap. Otherwise, the screw will not enter. And this patient woke up with a torticollis to immediately take the patient back to the OT, again put the drill and revise and pass the screw. Sometimes you can get hypoglossical weakness or nerve weakness or marginal mandibular nerve weakness. Yes, there are complications. Anybody who says that there are no complications is probably lying or has not operated enough. Don't believe that person. Everybody has to go through his own labor pains, to be born. And then, of course, this work got published. This was the first paper on the anterior surgery which I published from Japan way back in 2013. I had started doing this operation since 2005. And this was the first time where I had mentioned that unilateral approach with bilateral screw plate fixation and wedge bone grafting has not been described in literature before. There was no description of this technique anywhere. People had done on cadavers, but nobody had shown long-term fusion of the C1, C2 joints with plates across both the joints separately. This was in 2013. Then, of course, subsequently, other places, this treatment could be used, for example, like this tuberculosis on one side. This would have ended up conventionally in most places with occipitocervical fixation. So this was treated by one side, unilateral plate and unilateral trach. There's a lot of bone available. You have to study the bone, study the spine, take a 3D image of the cervical spine, and you'll find there's enough bone available for you to do fixation and get the reduction. This is another example which has gone into slight malunion. Now, this is another case of torticollis. I feel that, most of the structural torticollis are because of the abnormal development of the superior facet of the C2. And because of the abnormal inclination, the correct, I feel in my hands, repositioning, opening the joint, repositioning the joint and fixing the joint on the opposite side and putting a lot of bone grafts in this side helps me in correcting this torticollis. You can see this example, a long-term example, this is more than 10 years, and you can see the fusion on both the sides, good solid fusion and 2 screws with fusion across the joint, and this was immediate, and this is over 10 years, the torticollis is gone. This was another patient of torticollis where I used to fix lateral mass on one side and use the lamina on the other side after opening the joints to correct the torticollis. This was one of the things which I had published long ago. But of course, I feel anterior surgery is better. Now, this was pre-op and this was immediate post-op by doing this technique. Then my attention was caught by odontoid fractures. You will see in odontoid fractures, we all know that type 2 odontoid fractures have to be fixed and get operated. But why are they operated? They are operated either because there is instability, means the transverse ligament has been disrupted, or they will develop instability in the future because of avascular necrosis. Most of the patients are operated for anticipated instability. But odontoid fractures is a very complex disease. Odontoid fractures in young patients and odontoid fractures in elderly are 2 different diseases. Odontoid fracture in the young patient is associated with a lot of musculoligamentous disruption. It can be associated with other fractures like Hangman's and Jefferson's. So odontoid fractures are not very simple disease. You have to evaluate each odontoid fracture very carefully and decide what kind of treatment you want to offer. The conventional treatments for odontoid fracture has been the screw described by Nakashini and Bowler, and it became very popular, and all over the world they started using it. But I feel that the odontoid screw is a very, it's a good operation for a very limited group of patients. I will tell you why. If you review the literature, there are hardly any RCTs about odontoid fracture fixation. The last RCT was somewhere in 2014. If you will see recent literature, you will rarely come across a proper randomized controlled trial. And there is no question that surgical stabilization of odontoid fracture improves survival between 65 to 85-year-old people. The complication rate of non-surgical treatment is similar to complication rate of surgical treatment in the very elderly. And that posterior atlantoaxial fixation odontoid fracture elderly has the greatest bony union rate. But now, if you will see the literature, recent literature, most of it focuses only around osteoporotic old peoples. It does not focus around young patients. All the literature, mind you, is directed towards osteoporotic fractures. This is osteoporotic fracture. Odontoid screw is a poor operation because there is nothing for it to hold. It is going to fail. It is doomed for failure. Again, odontoid is not a weight-bearing bone. Basic principle of orthopedics is that in a non-weight-bearing bone, you do not pass an intermedullary screw, you do a plate screw fixation. Posterior C1, C2 fixation in odontoid, I think, is like an external fixator. It does not address the fracture. It is an external fixator. External fixator is good, but it takes longer time for the bone to heal. So what are the limitations? Inability to add graft material. Patients with short necks, you cannot do odontoid screw. Transverse ligament has to be intact. The fracture line should be in a horizontal plane, but fractures don't read textbooks. Anterior technique should only be performed if adequate alignment can be restored before screw insertion. There's a group of patients where the LR ligament has been disrupted, the fascial alignment is not there, there is a comminution of the fracture, the displaced impacted fracture odontoid, and there are fractures involving the superior facet of the axis and fractures which are associated with Jefferson hangman. So you need an operation which can treat all kinds of fractures and not just that single. Now you see if the fracture, if your screw does not go perpendicular to the fracture, this is what happens. Hardly any time you will find an ideal fracture where you can pass the screw perpendicular to the fracture. The other problem with screw fixation is that you must always transgress the distal cortex. The proximal screw head must sink into the cortex. There should be adequate amount of bone in front of the screw. Too many demands. And you ask yourselves, how many of you do this odontoid screw in this way? Hardly anybody. And this is what happens. Now this is an odontoid fracture. It has not engaged the distal cortex. It has not gone inside. There's hardly any little bone. Doomed for failure. This, I told you that this is very poor to do odontoid screws in elderly people. Now displaced impacted fracture, which has gone beyond. Sometimes these patients in India, they will reach you late. Now this kind of fracture, the only option would be transoral odontoid excision and posterior fixation. But this was treated by anterior realignment and anterior transarticular screws without any posterior surgery. So the concept is a VSP concept, the new treatment for unstable odontoid fractures. So you pass one screw in the center and one at the edge, and as you tighten, it will slide and compress the fracture. This is a basic principle of orthopedics. So if there's an anterior slanting fracture, which is a contraindication for anterior screw, you do the VSP plate. And the VSP plate will fix the fracture in compression mode, enhancing the fusion, which is a standard principle in orthopedics. This is a displaced fracture, where you can impale the fracture with the atlas, reposition it, put a plate. See, the second screw has to be passed very close to the edge, tightened, and then because there is associated atlantoaxial instability, you can pass the transarticular screws at the same sitting. There is no need to turn the patient upside down. Prepare the joints, pass the anterior transarticular screws. Now see, these are some examples. You can see this long-term healing of the fracture. Within 6 months, the fracture will heal. Fracture which is anteriorly displaced, impacted. Patient comes with neck pain because of atlantoaxial instability. Repositioned by impaling, realignment, and you will see that the fracture is healing. Over a period of time, you'll find that there is solid bony fusion. This should be the endpoint of fracture treatment. Reformation of the odontoid fragment, not just fixation. You must reform the odontoid. There should be bone across, the posterior cortex should be reformed, and the shape of the odontoid should be reformed. Another patient, you can see this over a period of time, how it is healing. So the scalars, then it heals, and then ultimately the fracture has healed because of the compression. This was the construct, a plate screw in the center, VSP with bilateral anterior transarticular screws. Now this is a complex fracture where you will find that there's a vertical fracture of the odontoid, there is a hangman's fracture along with it. This would have ended up in most cases with the posterior either occipital-cervical fixation or a C1, C2, C3 fixation, which I feel is wrong physics. Look at this, even in traction, it is not reducing. In spite of traction, it is not reducing. So this patient is treated by anterior plate screw, anterior transarticular screw, and discectomy fusion. And this you can see there's solid bony fusion. The odontoid is reformed, and all this through a small, insignificant submandibular incision without disrupting any muscles. So message is what? Fracture, realignment, and fusion are the endpoints of the treatment. Fusion of the atlantoaxial joints is mandatory if there is associated instability. Direct open reduction and fixation is possible in almost all odontoid fractures. Anterior plate screws is quick and easy. There is no risk of injury to the vertebral artery. Of course, this got published at various places, so you can go and see wherever it is now the literature. So potentially unstable fractures are those where there is a disrupted alar ligament, where there's loss of facetal alignment, where there's combination of the fracture fragment, there's displaced, impacted fragment of the odontoid, fracture involving the superior facet, and there is associated hangman's fracture. All these would have ended up either in posterior surgery and anterior surgery. All these can be treated by a single operation. And mind you, this operation is done in supine position, which is the position of reduction. You will reduce the fracture the moment the patient is in extension. So this is the construct. You can see how it looks on 3D. This is the disrupted fracture, and this is the instability. And then you can see how it is fixed, and over a period of time, this bone starts fusing. This was the implant. So the end point should be fracture reformation. And if there is instability, joint fusion. You must get joint fusion along with reformation of odontoid. So there are two aspects. One is treatment of the odontoid and treatment of the joint. Now this kind of fracture, there's a lot. This is a picture from Dr. Goel's textbook, fantastic textbook. And this was this, picture on there. And this patient of Dr. Goel came to me, I'm just joking, but this I reduced. And then what I did is I cut the longus colli muscle and the longus capitis and impaled the odontoid, repositioned it by using the odontoid, and then passed bilateral anterior transarticular screws. You can see this used for impalement and the bilateral with the bone grafts in the joint, and over a period of time, the fracture is healing. So these are kind of difficult cases, which you end up, doing wrong operation, and they can be little difficult. This I've shown this, this videos again. So this, although you are interested in seeing, they can go to the literature. And this was a paper I published just, I think, last month. In this paper, I have put forth this concept of how to treat unstable odontoid fractures, which are irreducible, that in spite of traction, they don't reduce. Then how to treat this patient? Almost every patient can be treated by anterior surgery. So you can go to literature. This is there online, this paper. I purposely published it in Journal Neurosurgery Case Lesson so that it is available free online for all those who are interested. The next thing that caught my fancy was basal invagination. Now, there is no consensus of treatment. Naturalist is clear, and best surgical approach is debatable. Again, Dr. Goel is credited with this concept of distraction fixation from posterior distraction, putting cages inside the joint. And of course, it was, depending upon the slope of the joint, how you can do these cases. And then Dr. Sarat Chandra came out with his technique of distraction, compression, extension, reduction. I don't know whether you have seen this technique. It is very, very fascinating, but very, very technically demanding as to how to do this case. I personally feel that certain type of odontoid basal invagination still need transoral odontoid excision. Dr. Goel may not agree with me. Dr. Sarat Chandra may not agree with me, but I still feel that there is a certain group of patients, for example, where there is fusion between the odontoid tip and the anterior atlas, those are not going to reduce whatever you do. So the problem is that atlas slips over the axis, there's venous plexus behind vertebral artery, etc., and the plexus, and like I told you, that the C2 spinous process is very important in craniovertebral junction. The muscles attached to it hold the falling head, which is falling in the front behind. Do not disturb these muscles. Cutting these muscles, putting implants over here will prevent the muscles from getting reattached and again acting. So the technique is simple. You push the cage from the front into the joint, and I'll show you some examples of this. These are the customized cages made for me by Jeon. And you can see this over a period of time, there's bony fusion across the joint. So the cages are put inside. There's a lot of bone available in the lateral mass of the atlas and the body of the C2, where you can fix with impunity without any fear, no need for navigation. Everything is staring at you. It's like doing an anterior cervical fusion. So you can see this, appreciate this atlantoaxial dislocation with basilar invagination and how it has been corrected. I feel that rather than wasting time with all these lines, the Grab-Oaks criteria, that is from the clivus to the posterior end of the C2, and the amount of odontoid going inside, that is what decides the cervicomedullary strain. In basilar invagination, what is important is to ask yourself, one, is there instability? And two, how much is the deformation of the cervicomedullary junction? And is that cervicomedullary junction deformation the cause of his symptoms? So you'll see this example. See, this is an example which is brought and corrected. And you can see the cages going inside and the fixation. So the technique is, simple principle of physics that if you put a wedge and hammer a wedge inside, it is going to lift the atlas upwards and backwards. This is the principle of physics, the wedge concept. Again, this is got published first, the technique I published way back in 2016, and then later in Neurospine. The video is there in Neurospine of those who are interested in seeing demystifying surgery for basilar invagination. And again, Journal of Neurosurgery last year, the video is there for those who want to see it. These are some examples. You can see this basilar invagination, and you can see this cage which has gone inside and how the odontoid has come down. I have put up to 9 mm cages, up to 9 mm. And you can see realignment. You can pull the odontoid in the front and then fix across the joint. And now this, the new thing which I've made, which is, where just like the ones used for cervical spine, where you can pass one screw into the lateral mass and one into the body of C2 downwards and medially. I've just done a few cases. So I'm waiting for my results to see the fusion and how it works and whether there are any failures. So I think I'm showing too many videos. Yeah, I think I'll show this. Yeah. So the concept is simple. The concept is like this. This is the joint. You open the joint and push a cage inside. The cage is going to push the lateral mass upward and get the odontoid down. This is a very simple concept. Now, the advantage of doing it from the front is that you can put a wedge shape. A wedge shape is, more bigger in the front, as it is going to push the atlas backwards. And you've got enough bone to fix. So that is the advantage of doing the surgery from the front. That you can impact a wedge-shaped cage inside. So I'll show you a little bit of how that cage. Now this is very simple. These are the points where you can fix the atlas and the body of C2 without any risk of injury to the cord or risk of injury to the vertebral artery. After dissecting, these are the longus colli muscles, and you'll find the moment you see that, you'll see the anterior arch of the atlas, and on both sides under the longus colli muscles, you will have the atlantoaxial joints. See, always the cautery has to have a plastic sheath on top so that it does not damage any structure around. Within 15 minutes, in most cases, you are on the atlantoaxial joints. This is like a cervical spine. Anybody who has done cervical spinal surgery. See this facet of C1, you're seeing so well. When you're doing it from behind, you're struggling, there's venous bleeding, you're frightened to the spinal cord. This is putting the drill inside the joint to prepare. Till there is bleeding. You can see the surface of the atlas is bleeding. This is the operation. The main operation is preparing the joint. There is a very, very wide space, in the joint. When you're looking from the front, you can put a lot of bone in the joints. And after you have put the bone, you can put the cage inside. Nowadays, I've started using peak cages, and you can impact the cage inside. So you can even manipulate the odontoid by impaling it. If you got it is not coming, you can hold it back into position. To treat any deformity, remember you have to create more instability. So if you want to treat a deformity, cut the muscles which are holding it in that deformed position, open the joints, prepare the joints, then you can treat the instability. See, we have to learn from the orthopedic surgeon in scoliosis surgery. The best results are when you do an anterior release and disconnect. Even in structural scoliosis, what is important is that you have to cut the bone which is causing the structural scoliosis. So if you are having a deformity in the CVJ, learn to manipulate the joint, learn to open the bone, whatever is fused, between the anterior arch of the atlas and the odontoid process. Remove the soft tissue between the anterior arch of the atlas and the odontoid process. Remove the ligaments over the joint, remove the ALL, cut the longus capitis, and you will be able to mobilize and reduce almost 100% of the atlantoaxial dislocations. Now, this is another new concept. See, this was a patient with basilar invagination, but there was a vertebral artery which was coming dorsally. So options, I had certain options of doing one side fusion and one side putting a laminar screw or mobilizing this vertebral artery. But then I noticed anteriorly, you see the lateral muscle overhanging, and that was the cause for the deformity. This facet had maldeveloped. I thought about TARP, which is a technique described from China, good technique, but transorally, I feel I'm very skeptical because there is no muscle, there's just mucosa and then the midline of the superior constrictor muscle. It looks very nice, but I think that wound healing can be a big problem and infection is a true problem when you're doing this kind of transoral surgery. I have done a lot of transoral surgeries before, and I have found that invariably the wound heals by secondary intention. I don't think it is a very good idea to have implants in the front, which is directly in the midline. Always the saliva is going to collect there, and the chances that they will heal with primary intention is very difficult for me to accept. But of course, these people have done a lot of work and they have published their work, but I find it very difficult. So then I thought of a new concept. This was the joint which is inclined downwards. I went inside, I drilled the anterior aspect of the joint and impacted tricorticate bone graft inside and put a plate from the front where I had a bicortical hold on the cervical body and 2 screws in the lateral mass. And this, because of the bicortical purchase, this was a very, very rigid construct. And you can see this. This is over 9 months, and then I published this. So this plate was devised where I can bend the angle of the plate sideways. This is another patient where I've used it. And you can see this was pre-op, this is post-op, and this was pre-op, and this is post-op. The odontoid has come down. It has this 3-point hold is a very, very strong fixation. And it got, of course, published as basilar invagination treatment by a novel implant. Then, of course, at another case where I've used this technique. And you can see another example where you can put a lot of bone graft and put the plate, and this is a long-term flexion extension. There is it's holding. So the technique is very simple. After having exposed the joints, you mark the midpoint of the anterior inferior border of the atlas, and then make a hole in that, tap the hole. Another hole you make in the center of the atlas after keeping the plate. I know the measurements, it is usually 3.5 centimeters. And then I make a hole in that in the anterior inferior border of the lateral mass. This is the plate with the upward flying screw holes. This special titanium plate made for me by the surgical company. I have no financial interest in any manufacturer whatsoever. And see, this is extrapharyngeal. It is so easy. In 10 minutes, you have drilled the hole, you have reached the spot, another 10, 20 minutes to drill the holes. And I try to see that how much length of the screw. So for the C2 body, I wait and take a C-arm, then I remove that and put the central screw in the C2 body so that I get a bicortical purchase. I am very particular that I get a bicortical purchase. So those who wish to see the videos, they're available on JNS. Of course, even if you Google and ask for atlantoaxial fixation, the first two videos are by me. I feel this is a redundant operation. This kind of fixation from occiput to C1 to C2 to C3 to C4. I don't know how can you do this kind of operation. So if the problem is in the front, you must operate from the front. Now, this is another new concept which was published by me for Atlas, where there is no place for you to fix. This is how the Atlas is to carry this earth on his head. I feel carrying the earth like this is simpler and less painful for Atlas. So this was a patient where somebody had done transoral odontoid incomplete excision with posterior fixation, which had got infected. I had to remove the implants, but there was no place to do any fixation. So this patient was treated by a new concept by me, where I transferred the weight of the skull onto the anterior aspect of the cervical spine. And this was over 7 months, where the flexion extension, there is rigid fixation, and the patient was up and about after about 2 months. So this concept was changed to this, transferring the weight to the front to the cervical spine. Now, this is a case where there's a fibrous dysplasia. There's hardly any bone available for fixation, and it is going right up to the spinous process of C5, C6, so nothing available. Lateral masses are also involved. So this was transfer of weight from occiput onto the cervical spine by a new construct. And this is over a period of time. Now it is more than 2.5 years. These bones are fused. I'm contemplating removing the implant. So this concept was very simple. You have to understand that there is hardly any structure lateral to the spine if you are at C2-3. So if you dissect lateral, just put the right angle retractor and dissect beyond the spine, there is no important structure over here. That is a safe area. So the rods, specialized customized rods bent at 90 degrees at 2 angles, were pushed into the muscle planes and then fixed in the front by a specialized connector. You can see that this transfers the weight, and there you see it is on the sides. So therefore, there is no difficulty in swallowing out. There's no pressure on the esophagus. And these rods are going to come out in the muscle posteriorly. Then the patient is turned prone. 2 paramedian incisions are taken without disrupting the midline muscle complex. And this special plate, you study the CT scan where there is dense bone and fix the plate to that. Then you can pass the rod through the plate, and with the connector, you expose over the rod. So the entire posterior tension band is kept intact. And then the head is pulled into position under the C-arm to realign it. And this is the final construct. So this is the patient pre-op. You see the instability, see the compression. And then it is, you can see this, no bone in between, almost hanging skull, in the air, and you can see this fixation. And then the patient was put on Demosab, and this lady, and over a period of time, it is ossified, and she's very happy that she was bedridden for 3 months, and she's up and about now, and she's very happy about that. And she's telling in the local language that now I can lift my hand, which I could not before the operation. So when there's a difficult situation, you have to come out and think about a new solution, and there are solutions. Of course, this has also got published as craniovertebral fixation, new technique in occipitocervical fixation. So for the young ones, remember to always study when you're talking about spinal fixation. Where is the force nucleus? Where is the line of weight transmission? Is there good quality of bone available? Doing spinal fixation without studying CT scans, I think, is the biggest disaster. The technique has to be safe and simple, and anybody and everybody should be able to do it. And just maybe, there can be a change in focus. My friend, Dr. Goel, published in 2017, way back, Atlantoaxial and subaxial cervical spine fixation. Can it revolutionize treatment, surgical treatment of cervical myelopathy? All problems drop when you are balanced. Remember, the balance begins at craniovertebral junction. We cannot solve any problem. Remember, problems simply disappear when we are balanced. Problems are just symbolic limitations. They are not real disease. The real disease is imbalance. My friend Goel has started talking about 2017. I'm waiting what will happen in future. But yes, the concept is fantastic. So this is Goel putting the cage from behind. This is Sarat Chandra using his, what called DCR technique, and this is my technique, which I feel is, more physiologically and correct because it is a wedge-shaped construct, preserving the posterior tension band. Doing surgery from behind is always adding insult to injury. If you will see Journal of Orthopedics recent publication, the present study reinforces the efficacy of the anterior submandibular retropharyngeal release for correcting deformity. There is no question that release of the anterior muscle is important for correcting deformity. Now, if you can fix it from the front, there is no need to go behind. Of course, there are going to be situations like this. Is transoral surgery totally irrelevant procedure? I don't think so. There are going to be cases like this where whatever distraction you do from behind, you cannot get rid of this. This patient is going to require a transoral orthodontic excision. Even in lumbar spinal surgery, there is a tremendous shift towards anterior surgery. Give me a lever and I will move the world. Archimedes had said that long time ago. The concept is that you should be able to put the lever at the correct place. You should have a lever which you can put in the correct place. If you can do it in the lumbar spine, why can you not do it in the cervical spine? So always ask yourself, is there a better way? Never be happy. If you are happy, that means you are dumb. A person who is not happy is always sad, keeps on thinking, and finds better and better solutions. Of course, this is my beautiful wife and my analysis for the last 35 years with whom I have been working and finding newer and newer solutions. Necessity is the mother of innovation. Research is search again. No knowledge is original. We only reach on old knowledge to find newer answers. Truth will come sooner out of error than out from confusion. You should not be dogmatic about anything. Dogmatic is doomed for oblivion. Thank you, my dear friends.
Thank you, Dr. Patkar, for this 2D force. Wonderful presentation, wonderful set of innovations, wonderful concepts, wonderful convincing concepts. And more importantly, the surgeon himself is convinced so much that he is completely in sync with what he is doing. So anterior surgery for craniovertebral junction region has been popular and many people in the world are doing. How much it is better than posterior, experience and time will tell. And I will see if there are some questions from the audience.
My co-host Libun Singh, any questions from you?
Thanks, Raja. Thanks, Professor, for very innovative and eye-opening lecture to all of us. What I want to ask from you, Professor, regarding the plate that you use, is it always flat? Because one of your plate that you curve at the side. So does the plate is aligned to the head of the screw or aligned to the bony surface? Thank you, Professor.
I always align the plate. I adjust the bone to accommodate my plate. I never bend the plate because the moment you bend any implant, the implant is made weaker. So make adjustments on the bone surface to accommodate the plate. I always like to make changes in the bone rather than make changes in the plate, because once the plate is bent, you have damaged the implant.
So you will drill the cortical surface of the place that you're going to put the plate from. Thank you.
Yes, yes.
Thank you very much. I would like to ask one question to Professor Patkar. What are the complications of your procedure that you have noted? As you have said, as you showed that screws are easily put, but reaching there is far more important. So do you have any complications with like retraction injuries to the facial nerves and hypoglossal nerves?
I showed that in the hypoglossal nerve injury, marginal mandibular nerve, but these are all neuropraxias. The secret, we all like, I don't know whether you are trained in general surgery. The trick while doing thyroid surgery is don't search for the recurrent laryngeal nerve. If you search for it, you will damage it. Similarly, in the submandibular approach, don't search for the hypoglossal nerve. Find out where you start in front of the C3 body and just with finger dissection go up, and you will not get hypoglossal nerve injury. But if you try to dissect and search for the hypoglossal nerve injury, you will damage the vasa nervosum. And with the microscope, of course, you can keep the approach very, very constricted to a very small amount. But yes, certain amount of patients can get neuropraxia. As you evolve in any surgery, you always evolve. It's like learning to ride a bicycle. In the beginning, you are going to hurt your knees. And then sometime you'll learn the balance and you'll learn the bicycle. If anybody says that I learned the bicycle in my mother's womb, is lying. You have to go through your set of complications. And like I said, hypoglossal nerve injury or recurrent laryngeal nerve injury, these are the potential. Then previously I used to use locally made implants which are not so good, and there was no locking screw mechanism. Then that could result in a problem. So I started using the locking mechanism. But the secret is, I feel, always to do the gardening very properly. If you loosen the joints, loosen the muscles, put the bone grafts properly, and do the correct gardening, then the fixation becomes simple. But if you're not gardened properly, if the deformity is not corrected properly, then your implant is doomed for failure.
What a wonderful talk, Patkar. I really enjoyed. We heard the term metacognition from Professor Dufault. You are an absolute example. I am reading from Google. Metacognition is an awareness of one's own thought process and an understanding of the patterns behind them. Examples of metacognitive activities include planning how to approach a learning task, using appropriate skills and strategies to solve a problem, monitoring one's own comprehension of text, self-assessment, and self-correction. You are absolute example of what definition of metacognition. What a great talk, Patkar.
Thank you very much. Our Swami Vivekananda had said that if you want to succeed with an idea, think about it, eat with it, drink with it, sleep with it, forget everything else, that idea will be brought into reality. You should get obsessed with your idea.
Thank you very much. We have Professor Ajit R here. Any comments from you, Professor Ajit R?
Yes, it's a very wonderful lecture regarding the new techniques, and so many new implants are introduced. But my question is regarding, because when you are putting these screws, you have to orient your trajectory. So many anatomical structures like a jaw and other things will come in way, and it is in the very depth also. You have to do a lot of dissection. Is it possible to direct your trajectory easily without doing extensive dissection, or through a very minimal dissection?
Yes, it is. You have to use the C-arm. If you got the C-arm, and once you see the lateral mass, the issue is passing the screw in the lateral mass. Passing screw in C2 body is not problematic. The problem is passing the screws in the lateral mass of C1. But you have to understand that the lateral mass of C1 are very big bones. There is enough margin for you to play around in the lateral mass of C1. So once you have identified the joints, all the bone above the joints is the lateral mass of C1. You need not expose the lateral mass of C1. You can see it on the C-arm in both AP and lateral. So once you have exposed the joints, all the bone above the joint is the lateral mass. Identify the midpoint of the joint, and once you have identified the midpoint of the joint, you are in the center of the lateral mass of C1. You have got enough bone available to you to play, to go medially, laterally. You have to always remember the lateral mass of C1 is less in depth medially and more in height laterally. So your screw should be always directed upwards and outwards in the lateral mass of C1. But the length available to you is very, very large. If you sit with the CT scan on the previous day, you can go up to 24 mm screws. You can even pass screws into the condyles, occipital condyles.
Thank you very much. I think we can hear the concluding remarks from Professor Goel.
Yeah, there are several wonderful pearls in this presentation. Craniovertebral junction is indeed a very complex game, very dangerous game. You do it properly, you give new life to the person. You do not do properly, you can devastate the patient. You can have deficit like no other deficit in the subject of spine or neurosurgery. So it is a dangerous game. So you have to be convinced about what you are doing, how you are doing, whether you will be able to do, whether you will be able to stabilize, and more importantly, whether that stabilization is the best in the world. So if you cannot do a semi-final operation whenever you are doing craniovertebral junction, you have to say yes, this is the way it has to be done. It is 100%. It is not let me try, let me see, let me think. So it is not like that. So in this presentation, you have seen anterior surgery and various permutation and combination of how to put screw, what are the philosophical ways to get a solid fixation, how your plate should be placed, how your screw should be placed, how to move the fracture segments, how to align the segments. There are several things, and how the other thing which has impressed me the most is to fix from front and then go suboccipital and do a two-stage fixation in a very dramatic manner. So there are issues which can be controversial, and those controversy are in every situation. If there is controversy, unless there is a controversy, there is no learning. So the audience should see them in the right perspective, have ideas, have conflicts in these procedures and conflicts in the other procedure, so you can also evolve and learn and progress. More important is to innovate, and more important is to innovate it nicely and perfectly for your patients. So my best wishes to all of you. Those who are doing craniovertebral junction are indeed the top of the line in the subject. There are, very few people in the world who are doing craniovertebral junction with conviction, with solidity, with perfection. And the problem is, as Dr. Patkar said, that there can be complications in every operation, but complications in craniovertebral junction can be absolutely, there can be no return from that complication. So you just cannot have a complication. I'm not saying you will not have a complication. If you give 20 lives, you may indeed make one fellow devastated. So that is, even that one person should not be devastated. That should be our aim. We should learn the anatomy, we should learn the technique, and more importantly, we should have a philosophy and have a concept. And also, more than anything else, you should have the experience in dealing with these situations, whether you are coming from anterior operation. I can imagine it is not very easy to come retropharyngeal and get. It may be easy for those who are experienced, and those who are doing from behind, it may not be easy because venous circulation, venous bleeding is there, vertebral artery is there, facets can be here and there, vertebral artery can be very high. So there can be various issues in both kind of operations. So you have to learn, and you have to do it properly, and you have to do it beautifully, because the indications are very far and wide. Huge number of indications for craniovertebral junction stabilization, atlantoaxial fixation, and those indications can be exploited in the favor of our patients. So thank you very much, Dr. Sushil Patkar, and my best wishes to you. You please continue your further innovations in the field, thinking, you must be thinking, you must be sleeping with these thoughts, you must be talking about these thoughts in your own self, and you must be coming out with great novelties. Thank you very much, and my best wishes to all of you who have been watching this program, and to Raja, and to my dear Liu. Thank you.
Thank you very much, Professor. Thank you.
Thank you very much. So because of lack of time, I'll close this officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to sincerely thank all the speakers and chairs for today, Professor Hugues Jaffa, Professor Sushil Patkar, Professor Masasumi Fuji, and Professor Atul Goel, and also distinguished dignitaries who joined us online, Professor Suresh Nair, Professor Takashi Kon, Professor Ajitar, and all the people around the world. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. Today, as I told earlier, we have more than 1,300 people who have joined us live on all three channels. A special thanks to my co-host, Dr. Liu Bun Seng from Malaysia, for joining in today. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you very much for joining.